Good morning and welcome to STD Engage 2023. Please take your seats. The program will begin in 2 minutes. Good morning and welcome to STD Engage 2023. Please take your seat. The program is about to begin. Please welcome to the stage Executive Director of the National Coalition of STD Directors, David C. Harvey.
Good morning, everybody. How are we doing? I have not been on this stage for a whole day. I've missed it. Good morning. Before I do introductions for what is a very important session focused on Mpox, I just want to do a final recognition for some sponsors who didn't have a speaking role at our various sessions, and I want to urge you to connect with them. Tom Carey is here from Let's Get Checked, Ben Sherman from Health Merck, and Aria Zummers from Color Health. Seek them out in the exhibit booth, connect with them, learn about the work that they're doing to support all of us. So, 1 year ago today, I cannot believe it. It's been 1 year. 1 year ago today, on this very exact day, our staff got a call from NBC News about a new and unusual case of Mpox in Massachusetts. Within minutes, we were in conversation with CDC. Within days, we hosted our first member call at NCSD. Within 5 days, we established the Mpox Command Center on our website. For us, these were the first moments of an incredible effort to respond to this outbreak. We raised awareness, we elevated the needs of all of you to respond to this outbreak on the front lines, and frankly, we worked to hold the administration accountable for what was a slow start that did let people get sick. I will add that we were ridiculed NCSD was ridiculed in those first few days for overreacting to this outbreak. I took a little pride because we were vindicated later on. It's not a great pleasure, though. We knew there was a serious outbreak, and we worked really hard to rally attention among the national organizations and others to this cause. So from there, we saw a monumental shift in how seriously and effectively this administration, the Biden administration, and specifically this White House, responded to Mpox with the appointment of Dr. Dimitri Daskalaskis to the co-coordinator role for the White House Mpox response team. I might just say as a side note, imagine if we had him there on a permanent basis working on STIs. Yes. Maybe we can get him to do that. So right now I'm going to ask our board chair, Audrey McDuff King, policy director for the STI program in New York City, to come out and help introduce Dimitri a little bit more. Please welcome Audrey McDuff King.
Today, David and I are so pleased to introduce Dr. Dimitri Daskalakis. For those who aren't familiar with Dimitri, I promise you are familiar with his work. Dimitri is an infectious disease physician who serves as the deputy coordinator of the White House National Mpox response. Prior to his appointment, he served nationally as a leader in public health as the director for the Division of HIV Prevention at the CDC. And I know him well for his local work as the Deputy Commissioner for the Division of Disease Control and the Assistant Commissioner for the Bureau of HIV at the New York City Department of Health and Mental Hygiene, where I work. It's that experience working on HIV and STIs at the local level in a health department and as a longtime activist physician working in deep partnership with LGBTQ+ communities that made him such an effective leader to the Mpox response. And I say that genuinely, not just reading off a piece of paper, even though I am reading off a piece of paper. Dimitri truly cares about the people, and in working with him at the New York City Health Department, I was continually impressed. It sounds like I'm sucking up, but I promise I'm not. I was continually impressed at how much he wanted to just be at the table with everyone else. It wasn't about hierarchy, it wasn't about titles, it was about working with the community and for the community. So I'm so excited to have him here today.
Thank you, Audrey. So we have both worked with Dimitri for a long time, and as we have said many times in this conference, putting the frontline experience, your experience on the national stage, is fundamental to ending Mpox and fundamental to ending the STI crisis in the U.S. Through the stress and chaos of this outbreak, Dimitri's leadership kept syndemics and STI prevention at the forefront. At each juncture, at each decision, Dimitri has been a champion for our sector, asking us what we needed and reminding the White House who was doing the work in the field. That same chaos, coupled with one very amusing webinar transcription era, brought to life the year's best nickname. Please help us welcome Dr. Dimitri Daskalaskis, a.k.a. Dr. Disco Lights.
Hi, buddy. Thank you. Yeah, it's okay. You can call me Dr. Disco Lights. It's stuck. Hi, good morning, everybody. Hello. So good to be among my humans. I always identify myself as first a sexual health doctor, STD doctor, and second an HIV doc. So, they're the same thing. So thank you so much for having me here, and thanks to David, thanks to everyone. What we're gonna do today, in the about 30 minutes that I have to talk, is to just see where we are, like assess the situation. It is an auspicious anniversary. I won't say it's a happy one, but there is an element of this that is joyous, which is that we really learned something very important from Mpox, that what we think about syndemics, interacting epidemics and responses that focus on syndemics, in fact, is the way to control an infectious disease outbreak. Next slide, please. Oh, that's me. So let's do... I'm just so used to so many things that are not as fun as a clicker that works. So quickly, an Mpox retrospective. So let's look at where we've been. All of the trauma. So I know you're not supposed to trigger people, but here it is. Just thinking about what we've been through. So there's a really good picture there of me being protested on the stage in Montreal. Friction and community creates fire, and that fire creates action. And so in this sort of grand tradition of HIV STI leadership and STI leadership and advocacy, you scream at the front and then talk in the back, and magic happens. And so it's such an important piece of our story. Like, we didn't have enough vaccine. We had a name that was stigmatizing, that was racist. We had problems accessing investigational therapeutics, and it was really hard to find a place to get a test. So that's what it was like May through pretty much July and August of 2022. And so what happened? Well, first, let's talk about the way that you respond to a public health emergency, and especially an infectious disease one. At its core, at its base, you really have to start with meaningful community engagement. And so that actually means talking to people, listening, and holding yourself accountable for what they tell you. So thanks. This is a lesson from the entire HIV STI story. This is what it's all. I look at my friend Harold Phillips there, right, Harold? It's exactly that. And then the next is political will. You have to have people who have power, who actually believe that they need to do something and move things faster. Then you have to, on that platform, really move quickly and innovatively with science to be able to address an outbreak or any infectious disease challenge in a meaningful way. So let's keep going down memory lane for a moment. So I'm going to tell you the story of what happened on my first day when I joined the White House to be the deputy coordinator for Mpox. So they were like, oh, there's a meeting. It's a Zoom. And I get on the Zoom, and there was a couple people, and they're like, well, someone's going to join us. And it was the president. It's true. And the president looked at, through the Zoom, looked and said, the reason that I brought you here is because I believe that we have to make sure that gay, bisexual, and other men who have sex with men, LGBTQ people, understand that we care about them and we are worried about their health. Do that first, and we're going to control the outbreak. Right, it's true. So when the leader of the free world says that to you, and you think about as a public health person, so much of my job has been trying to convince leaders that it's about the population and not just about the outbreak. And so that's a great way to start. And so then political will exists. You look at science, and things started to move. We changed the way vaccine could be administered to intradermal. You'll find out later today with new data that it is equivalent to subcutaneous. We literally moved to make sure that testing was moving faster and in places people can get it. We made sure that we accelerated access to tecovirimat, which is the investigational drug that's used to treat Mpox. Again, it's investigational. And we worked to make sure that we got vaccine as best we could into the community. And by that, I mean not just in clinics, but also in spaces where folks go. So all of those things came together, and we still have issues. We still have equity challenges. We still haven't done the most amazing job in terms of addressing some of the long-standing disparities. But when that science, that community engagement, and that political will come together, you all move the epicurve, not us. It was all of us together. And so that also means really being clear to our community and expressing how they can protect themselves with the knowledge of how Mpox is transmitted and how you can prevent it. So I think you've seen a quantum leap in federal communication, and then subsequently amazing uptake by the community in terms of magnifying it, making it clear that sex positivity is about knowledge, and that knowledge is power. And so really clear guidance that people understand is another really important component of addressing public health. It also doesn't hurt to have partners like Harold Phillips and Admiral Levine who literally show up for you. And we had people from across syndemic areas coming together to make sure that we were engaged with community, listening, and really keeping ourselves accountable. And so it is not a understatement to say we literally did 700 White House engagements to be able to make sure that we were connected to community. And so that's important, and that hasn't changed. So where are we today? It's Mpox. We've changed the name, the WHO listened to us, and it worked. We have adequate supply of vaccine, either because of intradermal as well as all the work to increase domestic fill and finish of vaccine and work with the company that produces the Bavarian Nordic MVA vaccine to make sure that we have adequate production. We have a capacity of at least 80,000 tests per day. And we have TPOXX across jurisdictions, readily available, and a study that's called STOMP that allows for remote access and enrollment, so even if you're not in an urban center, you can access the study. We are in a completely different place in May 2023 than we were in May 2022. And that is because of you, and it's not an understatement to say that without the STI and HIV infrastructure responding, we would not have had the success. But Mpox is not over. And there's so much data coming out today that will remind you that. CDC has released a risk assessment that says there's a substantial risk of ongoing outbreaks and an increasing cluster. So what we need to do is keep calm and finish the job. Thank you. Speaking of the job, let me tell you what the job actually is by going through some of the epi. And so this is where we are as of May 10th. CDC kindly dropped all the new data while I was on a plane, so it's not updated on my slide, but that's okay. So we've had 30,395 cases as of May 10th. That number has gone up a bit. We're gonna talk about the demographics in a moment. 42 deaths have occurred in the United States to date. We're going to unpack that number a little bit later in this talk, because it really does, I think, raise into awareness how Mpox was in effect just a grenade that was put into a space that really showed where we have inequities and challenges in our HIV STI infrastructure that we need to address, not just for Mpox, but prospectively. The darker the state or jurisdiction on this map, the more cases that were detected there. This is the epi curve as of May 10th. I'll tell you, it's not that different. National trends continue to be low. In fact, if you were to hover over the number for May 17th, the national daily average is 0. But that's because we actually have backfilling of cases, mainly because of the amazing efforts of our friends in Chicago. So shout out for Chicago. Yeah. Is everyone from Chicago? Oh my God. So shout out for Chicago. Amazing work, amazing collaboration between Howard Brown, Department of Health, and some of the organizations on the ground. It's been really remarkable. And so we're gonna talk about this in a second, but they've reported around 21 cases that are being backfilled, so we're still working with them closely. This is the only place to date that we are seeing this level of activity. So it's something that we need to watch like a hawk. And as I said to you, there's a substantial risk of ongoing outbreaks unless we finish the job. So not only is it about numbers, it's about the who, just not the how many. So 60% of cases in the United States have been in Black and Latino individuals. We're gonna revisit that number when we talk about vaccinations. The majority of individuals who have had Mpox, cisgender men, about 95%, and most of them are in that 31 to 35-year-old range, and we have folks on either end of the spectrum. Good news, younger folks actually have pretty mild disease, which is great to know. But we've not seen a lot of outbreak that has happened outside of sexual networks. So, where are we with vaccine, and what is our risk of future US Mpox outbreaks? There's a new risks model that came out today, a new sort of risk stratification. It's not new. In fact, at the end of March, CDC released a really important warning. And that warning was that according to their forecasts, we hadn't finished the job vaccinating the people that we need to vaccinate to be able to achieve the potential of control and elimination of human-to-human transmission of Mpox in the US. Note, that is also the WHO goal still, which is elimination of human-to-human transmission. The model asked the question, how much vaccination do we have to do to prevent an outbreak? And is there a threshold at which vaccine rates exist where we are less likely to see large outbreaks? So panel 1 says, the more you do, the better you are. So inverse linear relationship. The higher the immunity in the community, the lower the risk for outbreaks. And so again, obviously we want that immunity to be driven by vaccine and less by infection. The second part, 30 to 35% is the number that they found. If a population is under-vaccinated, below 30 or 35%, what then happens is we are at risk not only for outbreaks, but for outbreaks equal to or larger than the one that we have experienced so far. That is a call to action. And so I think what we also saw at the same time as the release of that model was complete transparency about vaccination rate by jurisdiction. And what we know in the US is that we are just squeaking by with first dose at 37% and fully vaccinated at 23%. Warning, Will Robinson, we have a situation. We have a job that we need to finish and we haven't done it yet. Now it's not because we haven't tried. Out of sight, out of mind. What you see with the vaccine curve, which I'm going to show you in a second, is as the cases went away, so did the vaccinations. So people either feeling that there wasn't a threat, not a risk, individuals not necessarily promoting it in the spaces that they should, all of those things came together to mean that we really didn't finish the job. The vaccine is safe and effective. I'm showing you some vaccine effectiveness data as well as safety data. Ignore it. Because today at 1 p.m., a tsunami of vaccine effectiveness data is going to be released. And that tsunami is going to tell you that it's a highly effective vaccine, about in the range that we've already spoken about, with some variability between the various methodologies. And one of the studies was actually powered to look at the difference between intradermal and subcutaneous, and it's equivalent. So watch for that news at 1 p.m. Also, as I said before, there's good safety data already published from the MMWR that really indicates that the vaccine is very safe. So, as a reminder, who should be vaccinated to prevent Mpox? So gay, bisexual, other men who have sex with men, transgender individuals, especially if they have some history in the past, STI or multiple partners. Now, it's important to say, and this is going to be clear in a second, this is just a way for you to think about who needs to get referred to vaccine, and also for people to sort of see if they see themselves in the guidelines. I'm going to tell you why the details matter less and you shouldn't sweat them. People who have sex at sex venues or large events, festivals, those individuals could benefit from vaccine. People living with HIV or other immunocompromised who have a recent or anticipated exposure, and any of their sexual partners, and that includes sex workers. So here's the punchline. Don't grill them. It doesn't matter. If they ask for a vaccine, they get it. At the bottom of the health alert, like CDC has said it before, but if you looked at the health alert that came out last week at the bottom, it is explicitly clear. Do not do extensive risk assessment. If someone comes, give it to them. And it's not just about the past, it's about, am I going to something in the future where I could potentially need vaccination? You know, the other part that's important, and you'll see this when we get to the death data, is some of the people who have the worst outcomes don't connect to so many of the services that we provide. So because of their situation, because of their scenario, they may not be able to access vaccine. And so that's why it's important that we increase vaccination among those who we have access to, because we're also protecting the folks who are less fortunate, who can't come to see us and can't come to get vaccine. So this is the curve I told you about that has kept me up for many, many months. It looks just like the epi curve. Like as the cases went down, the vaccines went down. So that's obviously not what we want to see. We want to pick up the back of that curve higher. And I'm telling you, if it didn't pick up this week after all the news, I just don't know. Some of us have dark histories of doing meningitis vaccinations in sex clubs, and it was really interesting to see that earned media alone was what generated all of the enthusiasm for meningitis vaccination. So exciting that after this, I am just in a continuous press junket, which is great, so we can get the word out. So one of the things that we saw with vaccine is that distribution and administration in the country was uneven, not only by geography, but also by race and ethnicity. And so this is a really great analysis done by CDC that in effect is asking what is the vaccine to need ratio, using cases as the way to judge that. And so what they found was that for every single case in a white individual, 43 white people were vaccinated. In a single case in Hispanic individual, 17 were vaccinated. For every single case in a black person, 9 people were vaccinated. I saw this slide and I go, I remember when I got the sort of advance of the MMWR, I was like, gosh, this is super familiar. And then I pulled the PrEP to need ratio of the United States. It's the same exact slide. That's called systemic racism. And so it's our barriers that we have that don't let people get the service. There are fault lines in this country, and so many of these infectious disease challenges go in the same direction. So the way that we disrupt it, at least for Mpox, is to vaccinate. The way we disrupt it for HIV is to think like a syndemic. If someone comes for sexual health service, think STI, think HIV, think Mpox, all of it together, because that's how people think about their own health. They don't think about this as the Mpox room. So think about how we can integrate that more. We have a cluster in Chicago, 21 cases. Breaking news, many of them were also vaccinated. Breaking news, we're not surprised. The vaccine is not perfect, but a lot of imperfect immunity in a lot of people is still a lot of immunity. And that's something that needs to be really important in the way that we approach our work. One of the other things that's important to say about the Chicago outbreak, and I'm gonna sort of see if my Chicago folks want to back me up. So far, it seems as if most of the cases have been very mild. That means the vaccine's working. So that's another really important piece of news. So thinking just like the way we think about influenza or COVID vaccine, that if it doesn't seem to work to prevent an infection, it seems to work to prevent worse disease, hospitalization, and death. So it's a win-win to keep vaccinating people and message that this vaccine has multiple roles in your life, potentially in preventing disease or the adverse complications. Health Alert came out soon thereafter from CDC, again, highlighting all the amazing information from Chicago, but then also reminding people that we have to finish the job in vaccinating, that we need to make sure that we keep testing, and that means testing people who have previously been vaccinated or have had Mpox in the past, just to make sure that we're not missing reinfections or infections after vaccination. So if you haven't seen the Health Alert, definitely worthwhile taking a look. So, let me talk about your toolkit. The sexual health toolkit is where Mpox prevention lives. It is a toolkit within the toolkit. What are the tools that you have? If we think about STI and HIV, it's always the same. It is test, prevent, treat, and respond. No different. Vaccine prevents infection and complications of Mpox. Testing identifies infections and allows for public health action, that's the response, and supportive treatments and investigational drug access. And if you think Mpox, think HIV, think STI, Mpox does not live in isolation, and I'm gonna convince you of that in just a couple of slides. And then finally, education. As you saw at the beginning of this, education is key. Informing people of how Mpox is transmitted is important so that they can make informed decisions about their sex lives and harm reduction. My friends, that is called sex positivity, and you do it every day. So thank you. Now, it doesn't just end with that toolkit. We've given you some more tools I'm going to talk about, which is that mental health resources and housing resources can be leveraged to support the Mpox activity. And so those are out in the field, and I'll make sure that I highlight them when we get to that part of my talk. Mpox therapeutics, where are we with TPOXX? So about 7,000 courses have been administered through the CDC EAIND, going back into our Mpox time machine. Yes, it used to take 2 hours to do all the paperwork. Now it's down to 15 minutes and maybe even less. But I wanna shift something in your mind. That is a really great way to get TPOXX, but it shouldn't be your preferred way, because we have made the STOMP study super easy. It is a telephone call, it is pharmacy delivery to your door, it is no in-person visit necessary, all of those things. Why am I promoting the STOMP study? Because we have no idea, none, if TPOXX actually works in treating Mpox. We know it's safe, and we know that it works in animals. And so really recruiting the study, and I'll tell you, the team, the NIH team that is doing the STOMP trial, oh my gosh, they are literally working overtime, not only to recruit folks in the US, but also to make sure that we're expanding sites across the globe. So we really want an answer to this, and it's really critically important. So EAIND is out there, but I'll tell you, STOMP is just about as easy, and it has an open label component so folks can get drug if they have severe disease or if they elect not to be in the randomized arm. So I hope everybody's taking pictures of that number so we can get the study recruited. And now I really want to talk about, I think, what David was framing before I came up, which is that it is a rare event that we have a new infectious disease that we can see literally entering a syndemic. And so I'm going to tell you the story of how Mpox entered the HIV, STI, mental health, and housing syndemic with pretty significantly deleterious effect. So what is a syndemic? I believe that you all know what this is. I believe that you live it. We've been talking about it in HIV, STI land for so many years. They are epidemics that interact with each other, and through that interaction have a worse outcome on the health of communities that already face systematic, structural, and other inequities. That's what a syndemic is. So let me put it into motion. So Mpox, HIV, STIs, mental health, substance use, all of those seem to interact. There's something about them. Is it that they're in the same population? Maybe. Are there biological things about them that can make things worse? Definitely. So what happens when they start to interact? Well, social determinants of health come together. Systemic racism, homophobia, transphobia, and unstable housing. And what it does is it takes this little mass of interacting infections and it galvanizes it into like a much more dense force that is able to impact the community in a way that some parts of it cannot. So the effect then is that we have significantly worse outcomes in communities who are the least able to afford it. So let's watch Mpox enter the story. This is the first data that came out of CDC in fall 2022 that was the first glimmer, other than anecdotal, that showed us that there was an interaction between HIV, STI, and Mpox. In a series of patients in multiple jurisdictions, 38% of individuals with Mpox also had an HIV diagnosis. 41% had had an STI diagnosis sometime in the year preceding their Mpox diagnosis, and all comers, 61% were either or. So they either had the HIV infection or they had a previous STI. That same study showed that not only were they living in the same zip code, in the same people, but that it appeared as if HIV was making Mpox worse. So people with Mpox and HIV were more likely to report severe symptoms, they were more likely to be hospitalized, and in this very early study, it was clear that the worse their HIV control was, the lower their T cells, the higher their viral load, the more likely it was that they were going to have a really bad outcome from the perspective of their Mpox. The next thing that happened was in October, CDC released a review about people who were hospitalized with Mpox, the 57 sickest folks in the United States that they'd heard about. A chilling 82% of them had HIV, and 72% had a CD4 count. I'll be clear, just to say it again, that's not their viral load. CD4 count of less than 50, which reminds me of my days in the 90s at Bellevue. So very specific and very terrifying. About 10% had taken HIV medicines in the past, and remember my little story of a syndemic, how systemic racism, housing instability all come together to make a syndemic worse, or actually generate that syndemic. Almost 70% were Black and 23% were homeless. At this point, you could predict what we were going to see in the deaths. And so I'm going to show you what we actually saw. But again, just given who was hospitalized in severity, unfortunately, it was not a surprise. So in April, CDC released the stories of the 38 people who at that point had passed away from Mpox. And what they found was, again, chilling. Most, about 87%, were Black. The vast majority, over 90%, were living with HIV. And for individuals who had HIV, all but one had a T cell count that was less than 50. Let me rewind that and tell you one other piece. The one person who had a T cell count that was greater than 50 had a T cell count of under 200, all late stage HIV. These folks don't necessarily touch you every day. They don't necessarily come to health environments, but they do come to environments where they look for housing, mental health, and substance user health. So it's really important to think, where are our opportunities to build Mpox into a syndemic story that includes these other critical components? Los Angeles County, around the same time, released a really interesting study. And what they asked was not about like who has Mpox and HIV. They were like, who has Mpox who we know has been experiencing homelessness, and what can we learn about them? Well, what we learned was that 60% were living with HIV. And of the individuals who were living with HIV, 50% were not virally suppressed, and 21% ended up being hospitalized, and I'm sure were among the mortalities that you just saw. So that really gets to the point that you need to have a syndemic approach for a syndemic challenge. And early on in the fall, when we recognized this interaction that we saw between HIV, STI, and housing and mental health, we were able to generate some pretty historic flexibilities, both in HRSA, CDC funding for STI and HIV, SAMHSA funding for drug user health as well as mental health, and then significant flexibilities in housing to allow people both with HIV and those who do not have HIV to be able to access housing if they didn't have it in the context of Mpox. So I can't imagine what would have happened had we not generated these flexibilities in terms of the outcomes. But it does remind you that really the syndemic problem that we have requires a syndemic approach. And the more we can build bridges between not only infectious disease, but the other components of response, the better we're going to be able to actually address the challenge. It is also important to say we, the global we, HIV, STI, keep the system warm. What if we weren't there? And what if we were better funded to be able to actually execute this better? What if at our baseline, EHE was fully realized? What if STI clinics received direct funding? What if we were able to actually look and say we have a national PrEP program to be able to create a force for chronic infectious diseases that can then be leveraged when you have a problem? This was the Mpox lesson. We do need a change. We have a problem with STI in the country, and Mpox is an opportunity for us to think about ways that we can better optimize the sexual health system to respond to our challenge at hand, which is in itself a major emergency, but also how we can make sure that that system is warm for the next one, because it is inevitable that we will have another emergency, and it is inevitable that the STD HIV universe will be in the lead again in terms of the response. We have been pushing not only for syndemic programming, but also some syndemic solutions and technology. We need a multiplex test. We need to test the tests for Mpox, syphilis, HSV1 and 2, and VZV. We have companies excited to do it. We have paths cleared at the FDA to get it done quickly, and we just need to have funding. And again, as you remember, with a lot of requests for Mpox funding, we didn't get it. So really critical to advocate in this space to accelerate diagnostics so we can actually approach our work with clear elucidation and enlightenment in terms of what we're seeing on the ground. Which really leads me to talk about where we are. So I know we've talked about where we've been. I think we've gone through the process of what we've seen. I think you all probably believe me that we are living in a syndemic with Mpox, HIV, STI, and that we really need to address it. But what are we doing now to move forward the mission for vaccine? So again, watch all of the media today. There's a lot coming, many releases, but I also want to highlight a couple of important things. We released at the end of March a really great website. If you haven't seen it, please do take a look. Think about linking to this website in your resources. It is syndemic messaging for summer 2023. It is not just about Mpox, it's about all of it. Travelers' health, it is about sexual health taken broadly, HIV, STI, Mpox, vaccines, etc. COVID-19 vaccination, and because you can't do infectious disease programming without thinking about drug user health, a section on overdose prevention. So as people get ready for the summer, please use this resource to really encourage them to actually, in effect, do a little like pre-summer check. Kick their tires, check their oil to make sure that they're ready to go into summer. We also have released some really good information in response to what happened in Chicago. So there's an even deeper dive into Mpox and summer events, and a page that's consumer facing that really talks about the reality of Mpox infections after vaccination. A bunch of other resources also exist. Happy to send them to David and team so we can send them out. From posters that are good for sex clubs all the way to videos of me and Leandro talking about Mpox vaccine in English and Spanish. They all exist to help really magnify the message. And I'll say, we have been doing this now for months. And so I just put up there quickly a group of organizations and people that we have worked with. So whether it is operators of large events, whether it is like trusted messengers in the community or other government agencies. We have been on a global tour, well, at least a US tour of all these places to make sure that we are not out of the woods and that we have real and present danger that we need to address by making sure that we teach people about Mpox, vaccinate them, and make sure that they have access to testing. This is where I just say thank you to you. I'm not done yet. This is just the love song part. I know you're like, are you done yet? This is the love song part, which is like, you all are the warriors. So much of the work that's happened has happened on your back. So much of it has happened without necessarily a lot of support. We want to make sure that we support you. We want to make sure that we think of ways that we can really magnify the importance of sexual health and STD work. And so I want to thank you for really being leaders and for taking that epi curve down. But here's the stuff that I need you to help me with still. The first is use your superpower as sexual health folks. You already lead with love, joy, and respect for the community. Keep that going. This is about ensuring that they have a happy, healthy life. Remember, vaccine is our best defense against Mpox. Don't do all that risk assessment. Think about who can get it. Promote good summer health. Use a syndemic point of view. When you're thinking HIV, STI, think Mpox and vice versa. Don't drop it from your list. So if someone comes with a lesion, make sure that folks remember to get it tested. And knowledge is power. Help people make informed decisions about their sex lives. And with that, I will ask you all, there's apparently mics somewhere here. If you have questions, please come up and I'm happy to take them. I think the mics are here. I am moderating my own questions, so we have about 9 minutes. So if you'd like to come up to the stage, I would love to take some questions. Thank you.
Good morning. Anthony Merriweather with the Alabama Department of Public Health. Just one quick question. We know and we understand that the time frame between your first vaccine and your second dose is 21 days. For individuals that did not come back for their second dose, do we have to start them over again, or what is the recommendation for
Fantastic question, and it's 28 days, so
28 days.
Which is fine. Okay. So just testing me, it's good. Make sure I remember. But we actually even have videos that answer the question. So I have it shot, and Leandro has it shot in English and Spanish. The answer is you just come and get your second shot. There's no need to reset. So it's just like some other vaccines. Like you just keep going and finish the 2-dose series, and then you're done.
Okay, all right, thank you very much.
Great question. Joshua. Hello.
Good morning, Dimitri.
Atlanta in
it's
the
so
house.
nice to see you. So I have a question. I appreciate the data in relation to intradermal and sub-Q being equivalent if you look at the data. However, I'm not convinced if you look at the human that is the case. And let me tell you why. I think, especially when we see hyperpigmentation for black and brown people, which is the spot that's left in intradermally, and the kind of it feels like more reactions in an intradermal administration versus sub-Q, where we found in Atlanta people were not returning for their second dose because of that spot, and it didn't go away within that 28 days, and sometimes it lasts for several months. And so if we know that we can switch spots, right? So you don't have to go in the arm, there's other places you can go. But given that, it still leaves a spot. And if we want to be transparent and upfront and honest with communities that we're trying to engage with these, we have to let them know about the harms that could potentially come from this vaccine. And if hyperpigmentation is one that's keeping them from coming back for their second shot or keeping their peers and lovers and friends from coming back for a shot, then how can we say that intradermal, I feel like intradermal would then perpetuate these racial disparities that we're seeing.
So these are great comments and questions. So first, I think that a couple of things. So for sure, the intradermal shot can leave a spot. It can actually last for months. And so I think that the first and most important thing is having transparency about this. So when you sort of see the person who's in front of you, like you say, the intradermal shot is this, it could do this. The other component of it is that our sort of planning dynamic for the vaccine that we have really requires us to keep doing intradermal as our first way of giving vaccines, sort of as like the global strategy. But if you look at what we have in the CDC guidance around this, the person in front of you dictates the kind of vaccine that they get. So if they want to get a sub-Q, no one's telling you not to give a subcutaneous shot. So that's important. The other part that is just like the stark reality is that people aware of having a spot is really important, but also making them aware that Mpox can leave like scars as well. Like I think if you sort of put it in that way and frame it in that direction and say, this is a mark, we can hide it in different places. The vaccine is effective in this way to make sure that more people can get the vaccine in the US. And if you don't want to do it this way, we're happy to flip to sub-Q. All of that is feasible. And I think that like really the more transparency you have on the ground about it, about the sort of risk, the better it is in terms of creating confidence and trust in the vaccine. So I totally hear you. And I think that we've done all that we can do to address the idea of where you can give it, but then also making sure that we're safeguarding our supply to make sure that we can finish the job with vaccine in the country.
Awesome.
It's
Thank
a
you very
balance.
much. I appreciate it.
No, you're great.
One additional part of it is even the spot like outed people in their workplaces and their families and things like that. So just it's important to keep these in mind as providers in the room in terms of the impact. But thank you very much.
And then also remember, like people, I've done this so much, and like a couple days ago, I was talking about the alternate locations, like the shoulder and back, and you would think it was the first time I ever said it. So just remember that the shoulder and back are places that are acceptable, and the back specifically can be covered by tank tops, can be covered with most clothes. And again, not everybody has a long-term mark, but some people do. So just like be very, very responsive to what the person in front of you needs, and all the guidance supports your decision.
Thank you.
Thanks, Josh.
Hi there, Zant Bryan from Washington State. I kind of have two questions, and I also want to validate. I got lots of questions from my spot on my arm. One thing is you talked about how much we saw in homeless folks, and so one of my questions is, are we going to continue producing vaccine and push to get homeless folks vaccinated as well, regardless of sexual orientation, and learn the lessons that we're learning from syphilis? Mm-hmm. And then on the other side, when we talk about finishing the job, if we had invested in putting monkeypox or Mpox to bed in the global south where it originated, maybe we would never have faced this if we had invested in the health of people of color in the global south in the first place. So are we investing in finishing the job there? Those are my two questions.
Sure. So question one was, well, first we'll do the Global South piece first. So there is a vaccine donation that has been sort of approved through the entire U.S. system. There are still administrative things happening outside of the U.S. to make sure that it can land in some areas, but we are working to make sure that vaccine lands, and also expanding some access to therapeutics and therapeutic trials in those spaces as well. Is it enough? No, and I can't go back 50 years to tell you that they didn't they did the wrong thing then. But I think that for sure investing in like the global picture is critical, both from the research perspective as well as the perspective of interventions like vaccine and drug. The first question, I already missed it.
Sure. So if we want to learn from the lessons that syphilis is teaching us, how do we get this vaccine into lots of homeless folks to prevent that from
there's
becoming
not a
an additional
specific
suffering?
Recommendation for people who are experiencing homelessness, because in the epidemiology, it's people who also have other risk factors. It's not just the homelessness, it's a risk factor. So based on that, and given sort of where we are with the outbreak, since it's really still focused on a community, like, you know, including an assessment for vaccine within homeless environments or where people seek care who are experiencing homelessness, with this focus still on sort of the other risk factors, is really the way to do it. So a global recommendation for homeless folks, the EPI doesn't sustain that idea.
It didn't for syphilis?
This is not acting like syphilis.
I know it's not fully acting like syphilis. I would just like to hope that we don't face with Mpox what we did with syphilis.
I think that one of the sort of exciting parts about this is by actually working with housing and HUD and HOPWA and actually embedding it as part of their mission. Like, I think we're already like way ahead of where we were when sort of syphilis reared its head within the homeless population.
God, I hope so. Thank you.
Good morning, Kathleen Roosevelt. I'm the Director of STD Prevention in Massachusetts.
Thank you.
Thank you. So I want to just first say that I really appreciate the talk about syndemics, the person-first approach. I think that's really important. But as an STD director, a lot of our funding is sometimes siloed and specific and comes with restrictions and caps on clinical expenses. And one of the ways, especially when we were dealing with Mpox early on in Massachusetts, we wanted to treat the whole person. We wanted to leverage work we'd done in the past with community servings and recognize that food is medicine and that someone is isolating and might need those kinds of services brought to them. And we faced those kinds of restrictions on that funding. So my question is, how are our federal partners working with us to support us to help us to break down those restrictions and treat the whole person?
Great. So I'll start in the Mpox space. So that's a great question. So I think that I imagine that you've seen all of these letters around funding flexibilities, like it's kind of an amazing precedent and one that I think is being thought about and pursued in sort of the day-to-day operations of how we do the work. And so sort of the letters that you saw from CDC that said like, use our HIV and STI resources to do this and don't worry about getting high-level PO approval to be able to do it. Use our, like the SAMHSA one was, I mean, frankly, was amazing. They were like, any drug user resource, you can't pay for a vaccinator, but you can pay for all the navigation. So I feel like this is the sort of case study that then lets us go back and say that we need to build more flexibilities as these new NOFOs are being rolled out. So I think it's like, you know, that your success and what you're asking for is being heard as sort of the next generation of funding is being developed. I hope so too. We're working on it.
Hi, I'm Leslie Feller from the Wyoming Department of Health. Thanks for taking
Wyoming?
Wyoming.
Excellent.
Yes.
Hi there. I just couldn't hear you. Hi.
Thanks for taking the time to be here today.
My pleasure.
When we're talking about a syndemics approach, I think pretty much all of my colleagues in the room have been taking a syndemics approach for a long time. Recently, that's come, you know, in the federal grants that we have to articulate how we're taking a syndemics approach. So while we're doing that, we're also finding that CDC HIV doesn't know what CDC STD is doing and doesn't know what HERS is doing. So we are very interested in taking a syndemics approach, but I think it's really important for the federal partners to know what the other federal partners are doing as well.
Amen. So that's definitely sort of as the structures like move into syndemic, I think that, and I'm speaking for the center, I can't really speak for them, but I just know from what they're doing, really thinking about ways that those interactions can be more hardwired so that it works better. I think that folks remarkably have said that Mpox has been one of the bridge builders between some of the various components so that that communication is even better.
I think one of the things also that's really important with that is lessons learned.
Yeah.
One of the things that we all experience for those of us that manage the STD prevention and HIV prevention is, everyone knows that HIV changed their grant year. There was not money associated with that, and there was a lot of very impactful, there was things that were heavily impacted by that, including the possibility of laying off staff and cutting programs. However, when STD then changed their year, on that federal call, I asked, will you be using lessons learned from the HIV, this grant year extension? And they had no idea that HIV had done that as well. And that's a missed opportunity to use those lessons learned.
Great. Yeah, I can definitely follow up with folks there to just make sure that that communication is better. Although I think that they did know, maybe not the people who were on the call, because that was a pretty high level discussion.
Okay, great. Well, thank you so much.
Yeah, my pleasure. And I'm out of time, and I know everyone back there is freaking out because it's blinking. So thank you so much. I think that's going to be the last question. Thank you very much.
Ladies and gentlemen, NCSD's Director of Prevention Programs, Leo Parker.
Good morning, Engage attendees. Thank you again for joining us this morning. It is a pleasure to introduce to you the second half of today's plenary entitled LGBTQ+ Health Equity. As many of you are aware, over the past year, we have seen an increase in anti-LGBTQ bills forming across our country. These bills target the lives of lesbian, gay, bisexual, transgender, queer, and plus individuals from healthcare to drag shows. This morning, we would like to discuss some of these bills and what you as providers can do to provide adequate and appropriate services to this community. I would like to introduce you to today's panel, who will provide information on these bills, how they impact services, and provide ideas on how to provide appropriate sexual health services to this community. Our speakers today are Jim Pickett, founder of Jim Pickett Consulting, Sean Cahill, Director of Health Policy Research, Fenway Institute, Bryce Furness, epidemiologist at the Centers for Disease Control and Prevention and DC Health, Terry Smith, Director of Sexual Health Services and Community Resources, APLA Health of Greater Los Angeles, and Sheena Menez, co-founder and CEO of Simple Health Kit. These speakers will be joined later by Josh Ferrer, who will moderate a fireside chat to dig deeper into some of the information shared today. Attendees, let's get this conversation started, and I look forward to hearing your thoughts later today. Thank you.
Ladies and gentlemen, NCSD's Director of Prevention Programs, Leo Parker.
Today. Beyond being the only employee of a cleverly named consulting business, I'm also, among many things, a Chicagoan. Can we have Chicago in the house? I'm a woke lefty, a Mommy Dearest fan. I'm married to my bestie, and I'm a gay man aging with HIV. So in August of last year, David Harvey and the NCSD MSM Advisory Committee lured me, consensually, to this gorgeous artist retreat you see on this slide called Eastover, which is owned by Tom Bertrand of the Rhode Island Health Department. Are you out there, Tom? And his lovely partner in the small town of Rochester, Maryland, to facilitate a retreat focusing on how we can collectively do better with, by, and for gay and bisexual men in our delivery of sexual health services. So we had a remit. We had two goals. One of them was to develop a strategic vision and some guiding principles, and the other one was to come up with a strategic plan for implementation. We didn't really get to the plan part, but we did a lot of work on the vision and the guiding principles. I'm going to walk you through those right now. But first, I'm going to tell you what we were informed by. A number of exciting and inspiring readings, including but not limited to The Joy of Gay Sex. Who was with me on that one? Hello, The Joy of Gay Sex. Thank you. And The Visionary Brilliance of Eric Rofus, the unofficial founder and daddy of the gay men's health movement. And The Denver Principles. Who's familiar with The Denver Principles? All right, I'm glad to hear some of you. I'm going to give you a quick history nugget. 40 years ago, in June of 1983, at the 5th Annual National Lesbian and Gay Health Conference in Denver, a dozen gay men with AIDS shared their experiences around stigma and advocating on behalf of people living with AIDS. They wrote out a manifesto, now known as the Denver Principles, outlining a series of rights and responsibilities for healthcare professionals, people with AIDS, and everyone concerned about the epidemic. It was the first time in the history of humanity that people who shared a disease organized to assert their right to a political voice and the decision-making that would so profoundly affect their lives, indeed my life. So here is the Rochester vision. The sexual health and wellness of gay and bisexual men and other men who have sex with men across the United States and across the gender spectrum will be prioritized, will be well-resourced, community-driven, pleasure-centered. Can we have a little love for pleasure? Intersectional and founded in equity. And it is supporting these 9 guiding principles, which I'm going to go through rather quickly. Recognizing that sexual health goes well beyond disease prevention and management, we center pleasure. We center pleasure and we foster sexual health and wellness. Foundational to our efforts, we embrace equity through all kinds of things, and we, including but not limited to, distribution and or redistribution of resources to under-resourced communities who are most impacted by sexual health disparities, and places where we need to do much better in terms of equity. Through a social justice lens, we actively disrupt status quo thinking. We advocate vigorously across local, state, and national contexts to dismantle racism, white supremacy, patriarchy, misogyny, misogynoir, homophobic and transphobic ideas, systems, and structures. Come on, there we go. Communities guide and provide our direction and guidance. We take all our lead from community. We honor a wide array of racial, ethnic, and cultural identities, socioeconomic statuses, geographies, ages, sexual identities, and gender identities and expressions. We uplift and support every single person in this big intersectional tent, and we practice all of this, cultural literacy, cultural humility, 24/7, 365. And we make room at every table in our big tent for new voices and perspectives, so mentoring and leadership development is incredibly important. As trust is not transactional, we earn and sustain trustworthiness every day. Trust is a practice every day. And our words are as important as our actions. We walk the walk and we talk the talk. Finally, we know that not everyone's going to be with us all aboard on this at the very same moment, so we strive to inform, educate, and advocate outside our big tents in the most endearing and effective way possible. James Baldwin was a writer, a truth teller, an activist, and a gay man. He died in 1987, but this quote on the screen could have been uttered this morning, right? I'll leave you with one more from this brilliant human being. Not everything that is faced can be changed, but nothing can be changed until it is faced. Thank you very much.
Please welcome epidemiologist, Center for Disease Control and Prevention, Bryce Furness.
Hi, everyone. I'm going to be speaking about the impact of anti-LGBT laws on our community. So we know that sexual orientation and gender identity disparities exist in STI prevalence, and that these intersect with racial and ethnic disparities. For example, with gonorrhea, we see higher rates among MSM and higher rates among Native Americans, African Americans, and Native Hawaiians and Pacific Islanders. With LGBT people, we also see other non-STI health disparities, such as high rates of cardiovascular risk, higher rates of myocardial infarction among transgender people, higher rates of diabetes and kidney disease, and behavioral health disparities, such as opioid use and depression. There's many causes for these disparities, but one major cause is discrimination and the consequent stigma and minority stress that it causes. So we know that stigma is widespread in our society, that more than 1 in 3 LGBTQI+ Americans experienced it in the last year. And this causes many of us to postpone or avoid medical treatment. It also has negative effects on our physical and mental health. For example, in Massachusetts, we had an anti-transgender ballot measure in 2018. And right after that ballot campaign, we surveyed about 500 transgender people in Massachusetts and Rhode Island, and found that those who had seen anti-transgender advertisements as part of that campaign had about 20 to 30% higher rates of depression, anxiety, post-traumatic stress disorder, and global psychological distress. Over the last 7 or 8 years, we've seen a sharp rise in anti-LGBT organizing and violence, as well as racist and anti-Semitic and anti-immigrant organizing and violence. So in Massachusetts, we've had white supremacists protesting drag story hours. We've also seen close to 500 anti-LGBT bills introduced this session, many of them attacking transgender people in particular. This is a map showing laws that have been passed restricting or in most cases banning gender-affirming care for transgender and gender-diverse youth. 4 of these states make such care a felony. But some states are also attacking gender-affirming care for adults, such as Florida, which has banned Medicaid coverage for gender-affirming care. Florida has also passed laws prohibiting the discussion of sexual orientation and gender identity in schools up to high school level. We've also seen violent attacks on LGBT pride, on LGBT nightclubs, and on providers of health care all over the country. All of this exacerbates significant pre-existing medical mistrust, especially among key groups. So, for example, older people in our community have a lot of medical mistrust because homosexuality was considered a mental illness until 50 years ago, when advocates, including Dr. John Fryer, who was wearing the mask in this picture, advocated for the delisting of homosexuality from the Diagnostic Statistical Manual of the APA. And this mistrust causes lower uptake of vaccine and reproduces the racial and ethnic disparities that we've been talking about this week, such that Black LGBT people are less likely to get vaccinated for COVID-19, and there's significant Mpox vaccine hesitancy as well among people of color in our community. This contributes to and reproduces the racial and ethnic disparities that we see in Mpox, with higher per capita rates among Black, Hispanic, and Native Hawaiian and other Pacific Islander community members. So a key question is, how do we ensure that the rollout of DoxyPEP does not reinforce these pre-existing racial and ethnic disparities? And it's important to note that many of the states where we're seeing the anti-LGBT political activism, like Florida, Texas, Oklahoma, South Dakota, Arizona, have large populations of Black, Latino, and Native American LGBT people who are affected by this activism. And this could worsen the disparities they already experience. And the last thing I'll say is, this all underlines the need for non-discrimination laws protecting our ability to access health care. About 30 states still don't have such laws. We have an administration that is enforcing regulations to protect our access to health care, but a DeSantis or Trump administration would, on day one, get rid of those protections. So we need a federal law as well. Thank you very much.
Please welcome epidemiologist, Center for Disease Control and Prevention, Bryce Furness.
To tell you something that you already know, that taking a comprehensive sexual history is important. But I'm going to ask you to expand your understanding of sexual history taking, and I'm going to introduce you to some tools that might improve sexual history taking. And I want to start with a quote by Dr. Wen. Public health depends on winning over hearts and minds. It's not enough to just have good policy. You have to convince people to actually follow it. We have national guidance for STI screening for gay, bisexual, and other same-gender loving men. We know that we need to do HIV serological testing if indicated. We know we need to do syphilis serologic testing if indicated. And we know we need to do gonorrhea and chlamydia testing, not only of the genitals, but also the throat and the rectum. But we can't follow these national guidelines unless we take a comprehensive sexual history. We need to ask about partners. We need to quantify the number of partners our patient has had, and in some instances for HIV testing, we should be asking about the partner's partners. We need to talk about past sexual history in order to past sexually transmitted infection history in order to quantify or understand syphilis serologic testing. We also need to talk about exposure. We need to talk about receptive oral intercourse, we need to talk about receptive anal intercourse, and we have to talk about insertive sex in order to determine which anatomical sites to screen for gonorrhea and or chlamydia. Above and beyond trying to decide through sexual history taking what tests to do and where on the body to do those tests, we also need to ask questions that let us know how frequently we should be doing this testing. If your patients are engaging in sex while high or drunk, then you may want to test more frequently than the recommendations suggest, which is annually. If your patients have a lot of partners, especially if those partners are anonymous or pseudo-anonymous, you may want to test more frequently than annually, which is what the recommendations say. I think we all know, or we understand, why taking a sexual history is important. We need to discuss sexual history in order to do the appropriate testing and focus our care based on that sexual history. This leads to better outcomes, better care, and better health outcomes. And a perfect example, basically, is you're seeing a young black MSM in your clinic. You do a good sexual history, enough of a sexual history to know that he needs a rectal test, a rectal nucleic acid amplification test for gonorrhea and chlamydia. You do that test, and it's negative for both gonorrhea and chlamydia. But because you also asked about past medical history, you found out that historically he had been diagnosed with a gonorrhea infection. And this young black MSM doesn't really know about PrEP and really does not know how to access PrEP. So this is what we're talking about with better care and better health outcomes. That young man, because of his previous rectal infection, needs to be educated about PrEP and linked to CREP, period. Thank you. So historically, we've talked about the 5 Ps of sexual history taking. I've already talked about partners. I've already mentioned practices such as receptive oral or anal intercourse. And I've already mentioned past history of STIs, that young gentleman with a past history of rectal gonorrhea. We also talk about protection, things like condoms and serosorting. And we talk about pregnancy, or we ask about pregnancy, family planning, protection against pregnancy, those types of things. But I'm going to ask you to include plus in your sexual history taking. I work with the National Coalition of Sexual Health. I spend a lot of time trying to get primary care providers to ask sexual health questions appropriately and then hone their care based on the responses to those questions. And the National Coalition of Sexual Health has come out. They've actually expanded it to the 6 Ps of sexual history taking and have included plus. And what is involved in plus? I think the most important thing that plus covers that the other 5 Ps don't cover is pleasure. You already heard from Jim about the principles, the Rochester principles. It needs to be pleasure-centered. So should our sexual control and our sexual history taking. Maybe we should move away from counting bacterial STIs and move towards making sure that if our patients are engaging in sex, that they're enjoying the sex that they're having. I want to also point out that we included in plus pride, and we want to know, we want to ask about pride above and beyond asking about sexual orientation and gender identity, because we know that if they don't have support because of their sexual identity, or they don't have support for their sexual orientation, they may be taking risks that they shouldn't be taking. And along those lines, we also want to ask about internalized homophobia and self-loathing, because that too can lead to increased risk-taking. So I mentioned the National Coalition of Sexual Health. There are a lot of tools out there that they have online. I encourage you to visit their website. They have a compendium of sexual and reproductive health services for healthcare providers. They have Sexual Health in Your Patients, a provider's guide, and they have sexual health questions to ask all patients. At the DC Health and Wellness Center, we have pocket cards for sexual health questions to ask all your patients. And these are given to every single person who comes through our clinic learning, whether it's a nurse practitioner, a PA, a nurse, or an MD. So I'm ending by asking you to help me change hearts and minds with not only encouraging history taking, and not so much in our publicly funded clinics, but in our Ryan White providers, in our FQHCs, and our private providers who see predominantly LGBTQ patients. But more importantly, I'm asking you to help make that pleasure-centered rather than just counting bacterial infections. Thank you.
Please welcome APLA Director of Sexual Health Services and Community Resources, Terry Smith.
Good morning, everyone. It is a pleasure to be here with you today and have an opportunity to talk about the impact on service delivery of these laws. I think I want to start by sharing a personal story. I came out at the beginning of the AIDS crisis. And it was a very scary time to be coming out into a community that had been devastated by this disease, where our government was not paying attention, was not really expressing any kind of concern, and yet people were dying. And what I saw was, among all that death, resiliency of our community coming together and protecting us, right? And allies coming together to build out service systems. And through that, it led to I think the beginning of the gay rights movement, right? We can look at things that came through from gay marriage, civil unions, LGBTQ protections, and all of that. And so that served as a springboard for where we are today. But where we are today is in a pretty scary place, right? Sean talked about all of the laws out there that are being put forward. Over half of them are targeting specifically the transgender and non-binary community. And it's a very scary time that we're in. And what I'm most concerned about in terms of impact on service delivery and people accessing services is that if you think about a young gay man who wants to come because he's having problems peeing, right? Or someone trying to access sexual health services, they're not going to do that because they're in a community that is telling them they're not worthwhile. They're in a community that is attacking the very essence of who they are. And the trouble with these bills that are coming forward is not only are they attacking the essence of who they are, they're also attacking the very things that protect us, right? So we talk about the sexual health toolkit, the prevention toolkit, right? They are attacking that stuff that's in the toolkit for people. Stuff like PrEP and stuff like DoxyPep and all this other things that they're attacking to impact our ability to live. And so as bleak as this all is, I do believe that as we did back in the 80s, we can beat this. But it's going to be for all of us to come together to make things change. And it's about us coming together as a community. And specifically, it's about straight folks standing up for LGBTQ rights. It's about gay men. It's about gay men and men standing up for a woman's right to choose. It's about all of us standing up for our transgender friends and non-binary individuals. Because although the other side, and I hate to say the other side because I don't want it to be us and them, but I think it's time to stop being nice, right? I think it's time for us to be clear that there are some deplorables that are impacting the way that we live. And so we have to come together as a community of people and push back against this because they have won many battles, but I believe that if we come together, we'll win the war. Thank you.
Please welcome co-founder and CEO of Simple Health Kit, Dr. Sheena Menezes.
Hi, everyone. Today we're going to talk about health equity and how as organizations, both from private, public sectors, have to come together to really push that needle forward and bring access to care really for all communities, rural communities and LGBTQ communities that usually get left behind in healthcare. So I want to start out with what is health equity? Health equity is when every person, every human, every community member can get access to care, not just any care, quality health care in an empathetic way, and irrespective of any social determinants of health, irrespective of your social economic status and where you live. And today I'm here to talk about our why. And typically we say what we do at Simple Health Kit. Yes, we build innovative technology and solutions, but what is our why, that why we wake up every day at Simple Health Kit, and what brings our team together? We fundamentally believe quality healthcare is a right and not a privilege. And thank you. But to you guys, really this is what we're all striving and working hard to do. And the way we go about doing it is really by thinking thoughtfully from the lens of the communities we serve, right? So we understand, hey, first step is just accessing a diagnostic tool. But what if you're positive? What if there is not enough infrastructure, providers? How do we make sure what we build has thoughtful follow-up care, end to end, leaving no human behind, no person behind? Today I want to talk about some of the challenges in rural communities and access to care there. 1 in 5, that's 20% of the United States, right, living in rural communities. And when you think of where is access, where are providers? We already know there's a shortage of providers in the space. 2/3 of US primary care, when you see shortages and you look at the map, you're going to see that disparity. So where people need it the most, there's not enough providers. And 1 in 6 adults living in rural areas uninsured. So what does that mean when you say access to care? A big chunk of access to care is making things affordable. And that's really what we stand. Like, we understand access to care, it's cost, what are those barriers? And that's really where we come in. So when we talk about now challenges LGBT communities face, a lot of this, and you've heard in my colleagues talk, is the trust in the system. You know, they've had it really hard, the communities. People, it's sometimes you don't need to be in the community to understand. It's more like having empathy. Lead with empathy. Understand what the communities need. So lack of provider knowledge is a big challenge today when it comes to LGBT communities. Discrimination. From the talks you've seen, it's really hard. And what does that lead to? Really, the negative past experience make that a barrier. So when we talk about stigma, yes, stigma is a big challenge when it comes to STDs, but now it's also fear to go into these health systems, healthcare systems. Am I going to be discriminated? Am I going to be neglected of healthcare? And look at the stats over there. They were blamed for their healthcare problem. 24% of communities were affected by that. Healthcare providers really stereotyping. So you can see so many challenges that LGBT communities face, and here we are trying to deploy programs as we work with state departments, county health. How do we deploy programs that are meeting people where they are at? And socioeconomic status, as I mentioned before. Limited income, lack of insurance, so even access or cost of a test is hard. When we look at now, of all those challenges and all the challenges already that exist in communities, no wonder you're seeing, when you look at the rates, STIs, HIV, syphilis, these rates are really, really large. And it's been, sadly, this pains me, and I would say everybody on our team here at Simple Health, like seeing these numbers really struggle, and it's always high. It's always communities of color. It's always underserved communities that always get left behind. And companies and innovation needs to be, for the first time, changing that needle. It cannot be a shiny object left for only those who can afford. We have to build tools that can address the people we serve and why we are in this space, in healthcare, to do this work. So at Simple Healthcare, we really built, for the first time, I would say, innovation in diagnostics, end-to-end healthcare, thinking through the lens of the people we want to serve and change that needle of, impact. So today we have all the way from your STDs and HIV and syphilis, we have expanded. And that's actually a pull, an opportunity where, there's one, meet people where they're at. So have a hybrid model of you have at home, in clinic. So have a system that, how can we deploy programs for states, for counties, federally, nationwide, deploying a PrEP program. STDs, this is all within our capacity, and talk to us from some of the challenges we've seen. Different communities, different states experience different challenges, and what we come in is as our team comes in, we look at all the challenges, we see, okay, which are the communities you want to serve? Which are the pain points that you haven't been able to address? And we work with you on solving some of those challenges. And just to give you a perspective, that if a test is positive, we don't leave you hanging. We don't leave a person hanging, because that could have been me. And if I was positive, I want to help. I don't want to be just a test and I'm out. So really, we have a whole follow-up infrastructure that can connect to telehealth. And if you're positive, for example, chlamydia, you have access to azithromycin. Today, we have built that experience. You've seen technology innovate in DoorDash and Uber and Lyft, and you have that whole end-to-end experience. For the first time, we're able to link that end-to-end care. So if you want an out-of-box experience, we have that. But if you want to be connected to FQHCs or your public health systems, we can do that as well. So this is a case study that was really passionate, I would say, to the team. This was right here in New Orleans, where a university and HBCU really wanted care all the way from STIs and COVID, and you're seeing this kind of a disconnect. People need care, but there's not enough infrastructure, and so what can we do? So for this partnership with HBCUs, we went there, we deployed the diagnostic solutions, STIs, COVID, and went to, and had to really understand from their lens, what are the challenges? Maybe, all the community engagement material. When people see that we look like them and they start to build trust in part of that engagement strategy that we actually deploy when we deploy programs. And what we understood is while we provided like at-home diagnostics, we also wanted to make sure that they were linked to potential follow-up care. So we partnered with an FQHC, and that team, DePaul Community Center, where the providers were just amazing. Dr. Green saying, I want to support these students. I want to help them because maybe they came in for STI, but as you know, potentially their diabetes, your kidney, and so that's another set of tools that we actually build because we know the disparity. Maybe that's the first step. Get them in for, I want to understand my wellness, but then we will be able to help them throughout their healthcare journey. So these are some of our partners, and I wanted to highlight different partners we work with, right? Because what you're going to see really quickly, they're very different types of partners, because what we're seeing is every community has different challenges, all the way from leading partnerships within communities with Walmart and some of the work we've done with the WNBA, to community colleges, to school districts, to state departments. We're actually deploying programs with LGBTQ communities in their state, how to even deploy that program. Usually when we work with, sometimes you don't need to know, and that's okay. And that's where we work together to find solutions that bring people together and actually push that needle forward for healthcare. So on that note, thank you, and I also want to leave you with one thing. When you think of health equity, what are the challenges that each of you face? And what are the things that really you're seeing pain points in whether it's state, county, wherever, FQHCs, what are the challenges you are seeing? And come talk to us. We want to help. That's where we've built for that exact mission and purpose. We're in aisle A, it's on the other side. A lot of innovation going on that really, really deeply, genuinely care to move that needle when it comes to public health and the communities we serve. So, thank you.
Please welcome NCSD consultant Josh Ferrer.
Good morning, everyone. So great to be here with all of you. So I want to thank the presenters for setting the stage so nicely for what's about to come next. We're going to invite them back on stage and have a little fun, a little fireside chat. So please join me in welcoming back to the stage Jim, Sean, Bryce, Terry, and Sheena. Great. So Jim, I am going to start with you.
Great.
We are very excited about the Rochester Principles. What do you hope to see happen with them? And let's imagine we're back at STD Engage in 2030. What had to happen to that point for them to have an impact?
We don't have enough time to go through every steps, but I'll try to make that short and brief. I think first what everyone can do when they go back to work, to their departments, to their organizations, their staff meetings, bring these ideas forward. I think it's a good time to assess some of these principles you may already be embodying and making real in your work. Other places you may need some support. I would love to see these things put into work plans and people being given charge of them. They're not going to work if it's like, oh, we'll all do this. Isn't that nice? Like, this is just all the organization has responsibility. Everyone has responsibility, but there needs to be a champion. It needs to be in work plans. It needs to be, there has to be metrics attached to it, as much as I hate the word metrics. And there has to be, outcomes and things like that. So I think that would be what I would hope. And then if in 7 years, we would come back and everyone is centering and resourcing properly gay and bisexual men. Pleasure is the watchword. All the other things are gone. And I'm going to tag on to something that Bryce said that I just love. But let's get rid of risk assessments. Out the door, tell CDC we're not checking those boxes anymore. It's all about, are you having a great sex life? That's the thing we ask. And then we help them get there.
Good. Goodbye risk assessments. Okay.
Goodbye.
Other thoughts on Rochester Principles and what it's going to take for them to really have an impact?
I don't think they heard.
Okay. Other thoughts about the Rochester Principles?
Well, I mean, I'm just going to add that, the Rochester principles are for us, by us, and it has to be adopted by our allies or it's not going to go anywhere. So I just want to put that out there.
And can I just add on to that really quick? It was something I should have mentioned. All of this has to be informed by community, and so there should be community advisory boards and groups of gay men of different races, genders, backgrounds, ages. It can't be all people with hair like this and hair like some other people on this stage. We won't look at it. Right, yes, Terry. We have to bring on new people and maybe people who don't have titles and positions yet, but are brilliant, have great ideas. It's up to us to be mentoring and bringing in this new wave that's going to usher in these changes.
Absolutely. So Sean, I want to move to you. The assault on LGBTQ rights, particularly the rights of transgender, gender nonconforming, non-binary individuals, has been deeply painful. And in the face of this assault, it's really easy to feel powerless or cynical. So where do we go next, individually and as a collective? What are some steps people can take to show support and really try to combat what's happening when they get home?
Yeah, thank you. There's a lot that we can do. First and foremost, support our patients and clients. Understand that all of this activism and these attacks on them affect their health, their well-being, their sense of safety and security as a member of society, their sense of belonging. So we should be using a trauma-informed approach to care in general, but especially for people who are being targeted like this. Also, speak out against scapegoating and discrimination. I know a lot of you are already doing that. You're already working to try to vote out the bigots, elect people who support equality and equity. But we can't necessarily control what the state legislatures do, but we can control what we do within our organizations. So make sure that your organization has a sexual orientation and gender identity non-discrimination policy. Make sure your staff are trained to understand what that means, and that they're trained so that they can provide affirming, culturally responsive, culturally competent care to transgender and non-binary patients.
Excellent. So talking about patient care, Bryce, you are a clinician amongst many other hats. You talked about the vital importance of taking a sexual history. Yet many of us in this room know that that doesn't always happen. So why is it so challenging for some providers to do this, and what can be done about it?
Good question, Josh. And I spent a lot of time working on this, but I think when you look at the scientific literature, especially among primary care providers, the 3 top reasons that they say that they don't do sexual histories is lack of time. The second one is a lack of knowledge about testing and treatment for sexually transmitted infections. And then the third, and the most disheartening for me, is that it's a lack of comfort with talking about sex or doing a genital exam. So I think I'm going to refer everybody to the tools that I already mentioned. The National Coalition of Sexual Health, they have palm cards and other guides that allow primary care providers and other providers to hone their sexual history taking and really focus on the important questions. That addresses the time issue. There are a lot of resources on their websites and CDC's websites that give you guidance on what to test for, how frequently to test, and how to treat the infections that you might identify through testing and screening. And then I think the third basically, well, actually I lost the third. What I will say is, when I started working with the National Coalition of Health, what I wanted, my goal was to get every practicing clinician in the country to ask their patients, are you sexually active? Where I am now, and based on the principles and discussions, I would love if they would follow that question up with, are you enjoying the sex you're having, period.
Absolutely. So, Sean, I want to come back to you. This question actually came up yesterday at the plenary on doxy-PEP, but I think it bears repeating again. And with this panel, you also had a question at the end of your slide deck about this. So, when PrEP was first rolled out, and then again when the Mpox vaccine was rolled out last summer, we saw that it was predominantly white gay men who were able to take advantage of these tools. And while we know, of course, this is the group that is impacted by HIV and STIs, there are other groups of gay men and transgender individuals of color who are even more deeply impacted by HIV and STIs. They did not have ready access. So with wider use of doxy-PEP coming soon, it's already here and it's going to only increase, how do we ensure it's rolled out in a way that doesn't reinforce pre-existing racial and ethnic disparities?
Right. I think this is the key question for this conference and for this moment that we're in. Most LGBTQ people, so I work at Fenway Health, which is a federally qualified health center and HIV clinic, and about half of our patients are LGBTQI+, about 35,000 patients. And we specialize in care for that population and HIV and STI prevention and care. We're one of about 20 LGBT-focused health centers around the country. Crescent Care here in New Orleans is another one. But most LGBT people don't get their health care at Fenway Health or Crescent Care or Whitman Walker or the LA LGBT Center or APLA Health. Instead, they go to the mainstream health centers. The other 1,400 federally qualified health centers, they go to STD clinics, they go to family planning clinics. So one thing I think is that it's absolutely critical that the staff of all the mainstream healthcare providers, the 1,400 health centers care for 30 million people in this country. They need to be trained in how to provide affirming, culturally responsive care to LGBTQ people, including people of color and immigrants, and to understand the cultural differences. And I think that will go a long way. But it's also about how we make things available. Like we did an analysis of the federal government's response to Mpox last summer, which is on our website, and I'm in the process of publishing a paper based on it. And as of late July, Washington, D.C. had received 14,000 doses of Mpox vaccine. Baltimore, Maryland had received none. And there were more HIV cases, new cases, and existing people living with HIV, new diagnoses, and people living with HIV in Maryland than there were in D.C. So it's also about equitable distribution and making the vaccine available broadly.
Absolutely. Other panelists' thoughts about DoxyPEP and really making sure it gets into the hands of the folks who need it the most?
Well, I think it's really important that there's also education and outreach specifically to those organizations that serve that community. And so some of them are grassroots, some of them don't have big, contracts and all this stuff, but they do have a in-reach into that community. And so really partnering with them, helping them understand, and then also in terms of the messaging that goes out to the community. Because I think that what happens with a lot of these things, if you're a gay white man or you hang out with gay white men and you're a person of color, you know about it. But if you don't, or you're not in that epicenter, if you will, then you're kind of left out of that information. So I think we need to get kind of out of our gay ghettos and really get into the community and begin to share information.
Great. So speaking of our toolkit, the buffet of options that are available to folks, we've got PrEP, we've got vaccines, and of course we've got these new tools and at-home testing, self-testing. So Sheena, I want to talk about you. You talked about the importance of making sure these tools reach rural populations. In an environment of fewer resources and of course a wide demand for services, how do we ensure rural folks, especially rural LGBTQ folks, don't get left out when it comes to accessing tools like at-home and self-testing?
Thank you for that question. Yeah, that's a very important, because sometimes the first step is just knowing where you stand. And what we've seen, when states deploy these programs, it's almost like multifaceted, like a hybrid. Yes, if you can come in, great. But you have to make it available for someone who can't access it, whether it's because of the stigma. Maybe there is no enough providers that understand them. You saw some of the challenges they're facing: trust, discrimination. So we have simplehealthcare.com, right? We have online. You can actually order it digitally, so you actually have a seamless end-to-end care. So for someone, if you're in a part of the LGBT community, you get a test. If you're, for example, multi-site. You want to make sure you have an anal, oral, rectal, right? So, or STIs, chlamydia, gonorrhea, and trichomoniasis. I kind of shortened that one. But essentially, if you're positive for any of them, you can go through an async telehealth visit, so you can do it in a private setting. These are clinical guided protocols. So there's a physician provider at every step of the way. So it's not just random. There's a physician ordering, there's a physician screening, all of that is very curated with providers and independent provider groups. But essentially the end-to-end experience. So if you are positive, you have access to a telehealth and you can get your prescription. I think that is the first time, bringing that end-to-end in a way that understands them and understands their challenges and their barriers, communities that kind of need this. That's kind of how we've kind of built all our technology and tools, and then we work with different organizations, FQHCs, maybe a hybrid model. Some who can come in, some you want to take home. So as we deploy now, we're thinking prep to get that out of the door. It's 3 months, 6 months, 9 months, depending, Truvada. So you have your monitoring, you have your frequent. So you don't want to drop that patient at 3 or 6. Maybe they have a flexibility. They could potentially get some of that work in a hybrid, and understanding, meet people where they're at really is kind of where we focus on.
Exactly. Definitely one of our mantras always, and now and forever, meet people where they're at. So Jim, there has been a lot of discussion around STD programs moving beyond a model where they're just centered on diseases to one where the focus is really on overall sexual health and wellness. And I think for some people this can feel a little foreign because we are, after all, in the business of preventing sexually transmitted infections. So what does this mean to you, this concept of moving beyond disease transmission, when we think about program design for LGBTQ folks?
So I kind of answered this a little bit before when we think about what sexual health is about. I mean, the WHO has a definition that's been around for a long time, and the WHO aren't a bunch of crazy radicals, right? And it centers pleasure. Yet we all get really focused on disease, how much did you do that? All this risk. I mean, we need to get rid of that word. Risk is I like a lot of 4-letter words. Risk is not one of them. Let's focus on pleasure and really, truly, I think I would break down in tears if my doctor sat down and said, are you happy with your sex life? Are you having a good sex life? As opposed to, what did you do? Who did you do it with? Did you know their status? Yada, yada. I mean, it's so dehumanizing and so demeaning. And it's so antithetical to our experience as sexual human beings. So I think we need to focus there and also remember that sexual health is part of holistic health. You know, I mean, we all we're focusing on navel to knee, but there's a lot that's happening up above that impacts what's happening from navel to knee. And there's a lot of fun areas up here too that aren't navel to knee. So we really need to be embracing people holistically, you know, like you said, meeting them where they're at, focusing on pleasure, getting rid of risk, and stop with the check boxes. You know, it's so interesting, you know, the CDC has new guidance around, relatively new guidance on PrEP saying, if you're sexually active and you're interested in PrEP, boom, you got it. Yet most of us are still doing assessments that have to check all these boxes. And you're probably checking these boxes because the CDC is telling you to, which is crazy because they changed the guidance. So we need to push back. If these tools aren't working for us, we got to tell our funders we're not going to use these tools anymore. We have one question. Are you happy with your sex life? Is there anything I can do to help you make it better?
Absolutely. So let's go.
I want to add to that, because we are so entrenched in counting infections. I think for me, above and beyond the pleasure-centered risk-taking and all of that, is doing better with what we do once we identify those infections. So not concentrating so much on counting these infections, but preventing the really bad sequelae of those infections. So like I mentioned earlier, if you identify a young black MSM with rectal gonorrhea or chlamydia, make sure they know about PrEP, start them on PrEP, or link them to PrEP. If you have a female, basically, who may be pregnant or is pregnant, make sure she's screened for syphilis to prevent congenital syphilis cases. I think that part of the evolution from where we are to where we need to be is doing more with what we already identify and count.
And can I jump onto what Bryce said? I think it's also about making STIs common and normal and routine and not a big deal. I've got many colds, and I get the flu and other kinds of crap. No one shames me for my cold. No one shames me for the flu, but oh my God, you get an STI, it's, you know, and that's really screwed up. And if we can just normalize it, it is a normal part of being sexually active. If you're sexually active and you're, popular and you're prolific, you're going to run into an STI. No big deal. Get screened regularly. You can get it treated and taken care of.
Yeah.
It ain't no big deal.
Yeah.
Absolutely. I agree with everything that's been said. I also think we have to address structural discrimination. Young people need sexual health education. They're not getting it. But also, a lot of the disparities, the racial and ethnic disparities, whether it's in STIs or things like why do Black and Latino women have lower rates of breast cancer screening, cervical cancer screening, why do they get diagnosed later and then have worse treatment outcomes? It's partly because they don't have access to preventive health care. Why is that? Because half of Black Americans live in the South, where they have not expanded Medicaid eligibility. And so unless you have a disability or are raising dependent children, you can be incredibly poor and not eligible for Medicaid. And then even if you're categorically eligible, you have to still be really, really poor if you live in Alabama or Mississippi or Texas to be able to get Medicaid. That shouldn't be. And when you put those things on the ballot, the majority votes for Medicaid expansion. So it's about, we need more democracy, particularly in the South.
Yes.
And I'm going to piggyback on what Sean just mentioned, too. Not only do we need to improve comprehensive sexual education among adolescents and young adults, we have to improve it among anybody who's training to be a clinician, whether it's a nurse, whether it's a PA, whether it's an MD. We need to be teaching these clinicians in training how to talk about sex and what to do about what they find out while talking about sex. It's not really happening, and it's definitely not happening in certain parts of the country compared to others. But we need to be educating adolescents and young adults about sexual histories or sex, and we need to be educating providers in training about how to talk about sex. It's very disheartening to me, and I'm now remembering what I forgot to say earlier, that the third biggest reason that providers don't take sexual histories is because they're not comfortable talking about it or not comfortable with genital exams. Done.
No, preach, Bryce. No, absolutely. So talking about the panoply of stakeholders within our community, Terry, you play a really important role in the landscape of HIV and STI prevention as a leader at a large federally qualified health center in Los Angeles, APLA Health. And you've got an audience here mostly made up of state and local STD prevention program folks. So what do you want your health department colleagues here and watching online to know? And as we think about reaching the LGBTQ communities, what are some ways that community-based organizations and federally qualified health centers like yours can work together with health departments effectively?
Yeah, that's a really good question. I think what Jim said about just the whole, I think specifically of like STD and HIV, when people access those services and the number of questions that they're asked, like they're just stigmatized again and again and again, right? And the answering or the asking of questions that are so irrelevant. So for example, in LA, one of the questions on our forum is, do you use poppers? What? Yes, no, I mean, what does that tell me, right? And I think that I would encourage health department people to really talk to their CBOs, who are on the front line with the community, to kind of hear what the community experiences by filling out these forms and some of the steps and hurdles that we have to go through to access services.
So Bryce, I want to make sure we got time. We've got only about 10 minutes left for my provocative question. So we, of course, continue to see profound disparities in STIs amongst gay, bisexual, and other same-gender loving men. And some folks have said, I'm not naming names, but some folks have said we just need to de-emphasize partner services with gay men. It's not effective, why bother? There are other populations more disproportionately impacted by STDs that do need to be reached by partner services. So what do you say to that? How do you respond?
Ooh, this was not a planted question, folks. So what I would say about that is I think that we're not giving gay men the benefit of the doubt. I think that they are interested in partner services, and we're just not working with them to provide that in the way that they want to. And whether it's because they want to self-notify, and maybe we should be asking more to be more involved in that self-notification, or because we're not using the technology to notify them that they're using to meet them. And I'm going to put up, I use the word pseudo-anonymous because I think of in my clinic, anonymous is you have sex with somebody, there's no way to reach them afterwards. There's no way to reach them. I think of pseudo-anonymous is you have sex with someone once or more than once, and you can reach them through the internet service provider that you connected with, Grindr, Scruff, Jacked, whatever it is. You know their profile name, you can message them through that. So to me, that's pseudo-anonymous. And then you have the folks where you know their name, you know their phone number, you may know where they live. I think that the real gap is those pseudo-anonymous individuals, which we can provide partner services to, but a lot of places we aren't.
Excellent. So, Jim, I want to talk about another provocative topic, and that's the use of the term MSM, men who have sex with men. When we gathered together to discuss the Rochester Principles and develop MEM, there was a very robust discussion in the room about the term MSM. Some people absolutely hated it. They loathed it with every fiber in their being. Other people were a little bit more open to use of the term because it takes into account populations like men who have sex with other men who don't identify as being gay or bi. So where do you stand on that? What are your thoughts?
Can you guess where I stand? Well, you know, because I kind of went on a rant on that. I set it up as a rant. So I'm not a fan of MSM, and I really dislike when people say the MSM community. What the hell is the MSM community? It is not a thing. And it erases community. Actually, there are gay communities, there are bi communities, there are trans communities, and there are millions of other ways that we're identifying now, which is really exciting and crazy. Like, so many people are identifying as non-binary or fluid, different gender, different sexuality, and that is brilliant. MSM just flattens it all. It takes away all of that. It's as if we're not also artists and creators and writers and loudmouths and everything else. It's not just about that we have sex with men. And to some of the points we've had before, and I think Bryce brought this up in terms of sexual history taking, me just knowing that you're a man who has sex with men doesn't tell me anything, not one iota about your vulnerability to STIs or HIV. What are you doing? What are you doing? I mean, if you're just jacking off with a lot of different guys, you don't really need a lot of partner services, do you? But if you're having anal sex, yada, yada. So we need to be more clear and why we're using that. And I think there may be places where MSM still fits in like the epi world. And I know there's like CDC people are probably rolling their eyes at me right now. But what the problem is when we use these terms, they get disseminated outward. And then we have MSMs. And I was talking to some MSMs the other day. No, you were not talking to some MSMs. It's so annoying. So that's where I stand on MSM.
All right.
You're never going to find one term that satisfies everybody. So
right.
I like saying gay and bisexual men and other men who have sex with men. I think that works. I think that this term came about in the late 80s from the federal government, maybe from CDC, around the same time that gay and lesbian activists were lobbying the New York Times to stop calling us homosexuals, because homosexual men and women or homosexuals reduced us to, this sexual act when we were so much more than that. We were creating families, we were, like you said, artists or whatever. So I do think it's reductive, and then there's other identities like same gender loving and two-spirit. There's a lot of identities out there. So I think having a broad, inclusive terminology is good, but it can't be too big. It can't so we do a lot of work also about collecting sexual orientation and gender identity data in clinical settings, and we're interested in how people identify as well as how they behave. So, and that's two different things. MSM is how people behave. Gay and bisexual or same gender living is how people identify. But it's important to have maybe a few options, but not 30 options, because you can't do anything with the data if you have 30 options.
And Josh, I want to add on to that for those of you, our allies out there, that we talk about cultural competency, but I want to throw into the mix cultural humility. So don't be afraid of using the wrong term if you're trying to use it in a way that's not disrespectful. So I use GBMSM, and Frank Strona taught me to use gay, bisexual, and other same-gender loving men. But the problem that I have with that is, like Sean said, it's mixing identity and behavior. And I don't have the answer, but we need to come up with something that doesn't mix identity and behavior.
Good point.
Well, we've just got a few minutes left, and so I wanted to give everyone an opportunity to provide some final thoughts. And I want to ask that everyone also touch on what is one action item, one piece that folks can take away when they get home after this conference to really help promote gay men's health equity. What's one thing you can do when you get home? Jim, I'm going to pick on you because you're closest.
You're looking at me first. And then everyone else will build on it and have much better ideas as they go. That's how it works, iteration. I think if the one thing everyone can do is, in terms of like the Rochester principles that we presented quickly here, is go back to your organization and your next department meeting or your next staff meeting and bring these up and and start to have that conversation in your organization. How are we doing on behalf of gay, bisexual, and other same-gender loving men, and whatever other acronyms, right? Not MSM. How are we doing, and where can we be doing better? Get the conversation going. Take the first step. You'll have many more steps to take after that, but you still have to start with that first step.
Absolutely.
I'll say two things. One, about the issue of sexual pleasure. We're a community of resistance, and I think having sexual pleasure, finding that and finding love is an act of resistance. Our whole lives we've been told things like, you can't be in the military, you shouldn't be part of this faith community, you shouldn't bring your partner to this family party or this wedding, you can't be in the St. Patrick's Day parade or the South Asian Day parade, And so our very existence is an act of resistance, and I think finding sexual pleasure and love is also a manifestation of that resistance. The one action step that you could take is Google National LGBTQIA+ Health Education Center. It's a project of the Fenway Institute, and there's lots of stuff on there that you can use to help train your staff and colleagues and just increase your cultural competency to provide care to LGBT patients.
Okay, I'm going to give you three concrete steps that you might be able to use to improve health equity in your clinics or your programs. The first is going to piggyback on what Sean said. Also Google a National Coalition of Sexual Health and look at all the tools and things that they have on their website. The second thing is I'm going to ask you to move away from quantifying sexual partners and move towards qualifying sexual partners. So your friend with benefits, where you discuss HIV status and STI testing history, is much different than that anonymous partner you met in a sex club. And we need to start treating those partners differently. And the third is to quantify, instead of quantifying infections, qualify those infections. So chlamydia in the throat of a 23-year-old female is much different than chlamydia in the rectum of a young black negative HIV negative men with MSM.
Yes.
I felt like an applause line was coming, so I was like... So I agree with everything that was said. I would just say that it's important for people to vote.
Early and often.
Yeah. And oftentimes we get so caught up in the presidential election and even maybe senator and all that, but I'm talking like every single lever of government we need to be voting. And voting for people who support the rights of all people. There were many straight folks that voted for Trump because of a tax cut, perceived tax cut, right? And they had LGBTQ people in their families, right? So when people voting, thinking about their community, their family, their members, and all the other stuff, because I think voting is just really, really important. So vote.
Yes, yes.
Yeah. Like Bryce, I'm going to give top 3 things I think we can do together. I wanted to start with a wise physician who is now a chief health equity officer, had coined the term, Dr. Gray had coined the term, prioritized communities, or priority communities. Too often we say underserved, and they always get left behind. I think now we have the initiative to actually move the needle and coin the term, continue to coin the term priority communities is where we need to put efforts in. So take away, if organizations come together, identify an equity officer, health equity, whose kind of mission is to say, hey, what are the communities we are serving today, whether it's rural, LGBTQ, and come up with initiatives to move that needle, because we have to move that needle. And how can we do it? Because it starts daunting from all the, and like I said, we work with government entities. It seems challenging, but talk to similar community members, talk to us, and see how we can deploy programs. And we can start small. We don't have to solve the whole world's problems today, but we can start something. But we got to move that needle. And yeah, thank you.
Well, I could easily have kept you all here for another hour or two asking you questions and keep you on the hot seat, but unfortunately we are out of time. This was certainly an enlightening and robust conversation, so please join me in thanking our panelists.
Thank you, Zach.